Good afternoon, everyone. I know you have been sitting here patiently. We didn't intend to have you wait. I was told that Dr. Reddy is showing our guests around. Oh, there they are. Okay. So the reason why we put this meeting together, and I'm sure Dr. Reddy will go over the details, is we just had the Endocon meeting. And we had the opportunity to host a few people who are very eminent in what they do in the world of endoscopy, especially in pancreatic disease. And you are sitting at one of the meccas of pancreatic endotherapy and pancreatic disorders. There are a lot of people who claim to be centers of pancreatic disease, but it's not a very comprehensive management. So we thought we will take the opportunity, invite these faculty so you can have an interactive session. That is the whole idea and the theme behind this meeting today. So I know all of you have work to do, and some of you, I have seen you at Delhi. And hopefully, as soon as they come here, we'll get started. We have three lectures we put together in such a way that you will cover a breadth of the entire pancreatic disease and not just a single subject. So the subject is pancreatic disease, but we'll try to show other things as well. Most of the times, you end up seeing what can be done and what can be achieved. So we will take a little bit of a different flavor of what should you do, what you should not do, and what can be done beyond what you're doing. So we'll try to keep it interactive as well, because I know all the three speakers, and Dr. Reddy and I will moderate. I'm going to assure you that it will still end on time, so you guys can go back to your work and finish your work and get back to your families and loved ones. So bear with us for a couple of minutes. And in the meantime, if you have any questions, I'm happy to answer. Anything but pancreatic disease endoscopy. So how many of you are coming to DDW? A couple of you. 3, okay. Sure. So at DDW, we have started something. So there is an entity called the American Association of GIs of Indian Origin. And by default, I do not know how. I think this is when I'm going to teach you as you get better in life. Don't make eye contact. Sometimes you make an eye contact, people commit you to doing things and you don't realize what you're doing. So that's why I don't look into Sandeep's eyes, because he might tell me to do something and you have to say yes. So they signed me up to be the president-elect, so you will probably see me there. We will be putting together a program on artificial intelligence and its impact on endoscopy. So we will have multiple speakers there. So those of you who are able to come, please come. Otherwise, it's on Saturday afternoon from 3 to 5. Please come if you are at DDW. We will be sending out the details of the meeting and the flyers soon. It'll be a good opportunity for you to interact with other people, see what they have done in life, how they have tailored, because you don't have to necessarily walk the same path to find out that there are a lot of bumps on the road. You can ask somebody who walked that road how bad it is, right? So there are a lot of people who are willing to interact and help, and I think that would be a good thing. So how many of you are planning to do inflammatory bowel disease? Please make Dr. Banerjee happy. None? 1, 2, okay. Because it's a great area. It is evolving. There's a lot of stuff going on in therapeutic inflammatory bowel disease. We have newer drugs that are coming in that hopefully will help the strictures and fistulae. One of the drugs that they tried recently failed, but a failure does not mean that you should sit back and give up. Then you try for a better drug. So I think the way we are looking at it and treating, I think will change in the near future. So surgery probably will be the last resort. How many of you are going into hepatology? None. So, gastroenterology is not just endoscopy, but liver is part of gastroenterology. So unless if you guys stay quiet like that, people like my wife or endocrinologists will take away saying that liver is the largest endocrine organ. So, and worse yet, I work in a hospital and all of us hate seeing liver disease. So guess what happens when there are some abnormal liver tests? People call hepatologists, and half the time that patient ends up having a stone or a cancer or something else that's causing a problem. So you lose out on it, and then they start calling endoscopists they like. So tomorrow when you get into practice, you don't want to lose them, right? Any patient who has an abnormalities and LFTs, you want to get them, and then you want to decide who should see them, whether you want to see them or somebody else. So lesson learned. One day I said, why are you calling me for this? Next day they stop calling, and then now start calling hepatology, and then the hepatologist decides the care. So I would rather have you be in charge than somebody else telling you what to do. And how many are doing luminal endoscopy, not biliary pancreas, but just other things, EGDs, colons? You should, right? Because that's your building blocks. That's your you cannot do without it. So the reason I'm asking is it's become very fancy. Recently, I had a radiology resident rotating, and I asked him. So I knew he was a radiology resident, and I asked him, "What are you doing?" And this guy tells me interventional radiology.
The concept was you just do quick endoscopy, and colonoscopy. Now, since we are identifying multiple early lesions, early gastric cancers, early colonic lesion, and the people are doing ESDs and all in a more aggressive way. So, identifying the points, spending a lot of time, and then the way the Japanese used to do a decade earlier. So we are generally a decade behind them. So, because this is a renewed interest, and in luminal endoscopy, until unless we do a comprehensive, very and uh, detailed examination of the mucosal surface, spending time over there, like withdrawal time. Earlier, we used to discuss in the colonoscopy, because it has been very well shown that until unless you do proper more than 6 minute withdrawal time, you adenoma detection rate goes down. So if you want to improve on that, you have to spend good time and learning and relearning via endoscopy, luminal endoscopy, because pancreatobiliary remains the same more or less for the time being. Maybe in future we will have better, we can do cholangioscopic ablations and all on the guidance. What your
So
thought on that?
it's a great point, and this is what I tell our fellows. So what your mind does not know, your eyes do not see. So you could have been seeing this all your life, but unless you were told or you started looking at it and you say, oh, that is intestinal metaplasia, you don't start biopsying, then you don't start thinking about it, you don't do surveillance, you don't, start detecting early cancer. It's not like it's a new disease, it just showed up today. We didn't know what we were looking at, right? So I think you should keep yourself constantly learning and motivated. And it's, as life gets busy, as you become busy practitioners, and I think working together in a team helps, and working in an institution that promotes education, having these activities will help, because trust me, I don't get time to go and read a journal every day.
Really known unless you are doing something concrete. And right now it's easy for you. There's so many patients, there's so many new things happening. Take a small area, work on that, and learn statistics. I've learned it the hard way, because If you're not good at statistics, your papers don't look well. And India and our part of the world, we're doing a lot of good work, but it never gets to where. So what you are practicing, best part of it will come only when you write. And I think our fellows, you're working a lot, you're learning a lot. In practice, you'll do well. But what about our way of doing things, our practice algorithms based to our region never comes up. So I think all of you, your thesis paper first should be published. And then what you do now will add to your CV. Do you agree, Nalini?
Yeah, it's a great point. And when she says you learn about statistics, we don't want you to go start crunching numbers. I don't expect you guys to do like a 3-year statistical course. But at least you should know what to ask your biostatistician. This is the question that we are setting forth to look. Right. Unless you don't, yeah, you should be able to at least ask the right question. If you say, just like how you ask Google and it responds, if you want to go from point A to point B, you should say, I want to go from point A to point B, which is the best direction to tell. Then your biostatistician can help. If you just collect a bunch of data and then when you tabulate them, yeah, now I have 100,000 data points. Make something out of this. That's like telling you, yeah, take a boat, put a net on it, go for 2 kilometers this way, come back, maybe you'll get some fish. We don't know what you're going to catch. You might have a great shark, you might have nothing. So I don't think that's an exercise. And sometimes people do that. That's what they take a large database and say, let me see if there's a correlation. So the other thing when you start off thinking about doing some research is you need to come up with a hypothesis, right? So there is a hypothesis-driven studies that you need to do. Come up with a question, what will happen if I do this? And what is the underlying mechanism? And how can I study this? So oftentimes what happens early in the career, you'll say, I have done 100 pseudocyst drainages with this stent. Let me see what happens. So there's no hypothesis. Yeah, I have done it. See, I can do it. That's not really science, right? So you need to have a question, and then you can answer. You can say 100 pseudocysts. None of them seem to get transient bacteremia, or even if it's bacteremia, it's transient. Should I give antibiotics versus I should not give antibiotics? Now, that's a reasonable question. There's a hypothesis, you're studying something, and then you have an endpoint, right? So you're seeing how many people did fine with antibiotics, without antibiotics. It's an important clinical question you'll answer. So anything that you come up should have that kind of a goal. So long time back, I used to write papers and do stuff. Now I'm too lazy and too busy. So when you start thinking about this thing, your paper is almost ready, minus the stats and the results, right? Because you've already looked at your aim, the objectives, what your primary endpoints are, secondary endpoints are. Everything is written. You have reviewed the literature to the extent that there is. So finally, when the results come out, then you can say, my results are slightly different, better, or the same. If they're the same, why or why not? And nobody knows that better than you because you're the one who spent a lot of time looking at this. So you should do it in such a way. And most successful researchers and publishers, they have one study in the making in their brain. There's at least one study pending with the IRB. There's one manuscript that they are working on currently and one manuscript in the review. If you have that thing, so it's like a production, you will then be very successful. You will have, your publications. And just don't publish because you have to publish. And now I have 150 publications in some obscure journal. Doesn't really mean much. So the beauty is when you do a study, you want the results. So your baby is out. You want your baby to look beautiful. And then you work hard, try to present this. The reviewer comes back. They will say it's a terrible idea. Don't get disheartened. It's just their opinion. And you finally publish. So that's only part one of the story. Part two of the story is how many people actually read your paper, how many people felt that the results of your paper are so compelling that they need to cite your paper? So once your paper is cited, that means you've made some impact. That's why people look at citation in the indices of these studies. So yeah, you can publish, but how many times was your paper quoted and cited? That's the true success of your science. So try to inculcate it. Um, in 5, 10 years from now, when I'm sitting in the back benches, I would like to sit one of you stand here and give that talk. So, and things are catching up fast. People are using artificial intelligence, language models. So we will see a different kind of research coming through. If you use AI, now all the journals want you to state how much AI you've used and what exactly you've done. It's okay to use AIs which correct your language and correct your grammar, but you cannot make AI do your research. And there are AI programs that you can tell, and they can create a paper for you. And there are AI programs that can give you all the scientific citations. And that's where some of the countries are in trouble. And recently, one area in the world had a lot of publications, and most journals are withdrawing it because now they find that it was not done right. It was a lot of things was manipulated data. So the reason I'm saying this is credibility is the most important thing. It's a small world, the endoscopy world, the gastroenterology community. You might feel, yeah, there are 3,000 DM students right now in gastroenterology in India. But if you take 1.2 billion people, 3,000 is less than a drop of sand, a grain of sand on the beach. So you're a very small, tight-knit community at the end of the day. And your credibility is very important. So if Sandeep or Nitin or somebody tells me that, this is what we found, I should take it for face value. So that's the credibility that you want to get. So never lose your credibility. You have to double check your data, make sure. And there are a lot of times you work hard. A lot of studies take a lot of time, and sometimes it's a negative study. Sometimes the study doesn't. It's a classic example. How many times did ISRO launch rockets? Did we celebrate all of them? No. We recently celebrated Chandrayaan, but before that thing was successful, they had a lot of misfires and mislaunches. And in research too, you have a lot of papers that you think you're going to do something. Sometimes accrual is hard, and your study has to be terminated. Sometimes you get adverse events in your treatment arm that force the study to be closed. And sometimes it just is a dud. No matter what you do, the results are like, blah, you can't do much with it. So, but that does not mean you need to change something and try to manipulate the data. So if you manipulate the data strong enough, you're determined, your statistician will give you 1 or 2 data points which have a statistical p-value less than 0.05. That does not mean anything. Statistical significance is not always clinically significant. And so, a lot of times people have this idea, oh, if p was less than 0.05, so what, right? That does not mean anything. So what you do should be clinically relevant as well. And, keep it inquisitive, and I think you'll all be successful. You have a great team of mentors here. I don't know, I know you all work hard because I see a lot of patients waiting outside. Any questions anybody has? I'm not here to impart words of wisdom because I have none, but I just am making this up.
Any issues of clinical interest or research interest, get heart block or failure of ideas, and how to not able to relate to him. And some of our papers have been actually seen by him. He was so kind enough to polish our papers. English is not as of thoughts. Paper has to be things He has been very kind enough. And when we say that we'll put you as an author or as an acknowledgement, he refuses for that. He says, no, no, it's not my paper, it's your paper. Let it go as it is. It's a That's for friends of all who just do for without any hidden agenda. And I think we need friends like that around us who can just help you out without expectations. If you help out, then it becomes your moral duty to help the other guy next time when he needs requirement arises.
Sandeep was kind, but it's true. You just don't put your name. If you haven't done it, you have not participated in the conception, the design, or something significant, you cannot. So the other thing is that it is very important that all of you identify a mentor, a father figure, right? For lack of a better word. It's not like, they're going to guide you in your life on every little thing, but it's always good to have somebody you can bounce off an idea without worrying that they're going to steal my idea and run with it, right? That's what, Dr. Lakterke is saying. We talk. It's not like, I'm going to steal his idea, come out tomorrow with a paper. So we all need somebody like that. And we all need to identify somebody who keeps us true north. Sorry, I'm keeping them entertained. Right? I'm here. So they gave me a microphone and I couldn't refuse, and I've been hogging it for a while.
Okay. So we'll start. I'm sorry for the little delay because at the hospital tour took longer than expected. So we have, I think, very privileged this afternoon to have with us a very distinguished gastroenterologist and also cardiologist from US. And this thanks to Nalini. Nalini, we had this Endocon program in Delhi, and Nalini said, we are discussing, I said, is it possible to have them come over on the way, and he agreed. And I'm also very thankful because after 3 days of exhausting workshop to come to Hyderabad and then be with us, we're very grateful for that. So we thought all of them were actually experts in pancreatic diseases. So we'll have a pancreatic symposium covering 3 areas. I'll introduce each of them individually, but start with Marty Freeman. Marty Freeman, I think, who doesn't know Marty Freeman here can raise their hand. Everybody knows Marty. Yeah. So Marty is, I think, in 1996, it was the New England Journal paper, which we all quote, was the one which drew our attention to complications in ERCP. And since then, I think this has been the paper that every fellow has sort of reread, and so on. His contributions are many in different. In fact, people don't know that he was, I think, the first one who described the rendezvous technique with the EUS and in patients who had difficult access to the pancreatic system. There are many, many firsts that he has done. He runs a fantastic unit in Minnesota, and I think more than anything, he's a great human being. So thank you, Marty, for being here with us, and we'll start with your lecture first. Yeah.
It's such an honor to be here. I'm still trying to recover from our tour of AIG. It truly is the future embodied. So it's humbling. Bring up. Not sure where mine is. I think I thought I had. So it will be in there. And yeah, truly outstanding. I'll say just while I'm waiting, I had the pleasure of meeting Dr. Reddy about 20 years ago in Hong Kong at a workshop, and it's been a privilege to see all of this. And it's been a real honor and a pleasure to get to know him. Also say I'm very proud that 2 of my absolute most outstanding people that I've had the privilege to train are here, Nalini and Rajiv, Nalini Gouda and Rajiv Adam, who were both fellows advanced fellows with us some time back and have really become leaders, nationally and beyond. I'm going to talk about complications. Key points is ERCP safer, and with data I have are for the USA, and I think it might apply beyond the USA. NSAIDs are replacing pancreatic stents in practice, but are they effective, especially to prevent severe posterior CP pancreatitis? And I can't go through everything from A to Z, but try to convince you of the least known fact about what causes posterior CP pancreatitis. It's the guide wire, not necessarily the contrast. Perforations of all type can be not only recognized, but now treated endoscopically. So our awareness of perforations is critical. And then I'll skip briefly over endoscope transmitted infections. And then the big picture, which is the least necessary ERCPs usually cause the most complications. I think that's true of life in general and all procedures. And then how important it is to track complications. So I always like to start with a case, and these are all bona fide cases exact to the detail. 40-year-old male, chronic abdominal pain, post-cholecystectomy, normal liver enzymes, mildly enlarged bile duct, and endoscopic ultrasound. This is done by a very advanced trained fellow in practice, not fellow staff. Possible sludge by US, did a guide wire cannulation without contrast injection into the pancreas. I'm not sure what else happened. Biliary sphincterotomy, rectal NSAIDs were given, and IV fluid resuscitation. Patient was readmitted with very severe abdominal pain, necrotizing pancreatitis with multi-organ failure, dialysis, ventilator, shock, laparotomy for refractory compartment syndrome, multiple interventions, 2-month stay, and now I follow him in clinic years later, long-term disability. So what was different here, because nothing that was done was out of the ordinary, what might have been done differently to prevent this? And I think we come back to something that we've known for decades, pancreatic stenting to reduce risk of post-ERCP pancreatitis. The idea being to, yeah, thanks. You can tell my voice is a crack. Thank you. Might stay that way anyway. That going back, you can see 30 years of data, randomized controlled trials showing dramatic reduction in risk of post-ERCP pancreatitis, culminating in meta-analysis with about 70% risk reduction. What's really important is preventing severe pancreatitis. And this is a meta-analysis from Buxbaum's brilliant ASG guidelines, just published recently, that we've known for years that pancreatic stents virtually eliminate severe post-ERCP pancreatitis. So what's happened, though, is NSAIDs have been replacing pancreatic stents in practice. And are they effective? So this is a paper, actually Joel Munzer was part of this paper. It was in the American Journal of Gastro. And what you can see is that pancreatic stents were used in the majority of patients with high-risk ERCP. And then starting in 2014, 2 years after the seminal New England Journal paper from Joel Munzer showing efficacy of NSAIDs, pancreatic stents virtually disappeared almost as fast as the dinosaurs after the asteroid hit. And then you can see they went from from very high usage to virtually non-existent, relying on NSAIDs. Now, coincident with that, in a different study, which is over 1 million patients in the US, starting that same year, the incidence, severity, and mortality of post-ERCP pancreatitis started to climb significantly. And that was, interestingly, in a time when sphincter of Oddi dysfunction, which probably never existed in India, but was very in vogue in the US, kind of faded away because of another seminal study by Peter Cotton and all. And that is the highest risk group of patients. So you have a rise in severity and mortality of pancreatitis despite a phasing out of the highest risk indications. So suppositories versus stents. What do we know about it? Well, now we have a phenomenal prospective randomized trial run also by Joel Munzer of New England Journal NSAID efficacy fame, and very extensive 2,000 patients randomized nationwide, National Institutes of Health funded. And it did show significant added benefit of pancreatic stents over indomethacin alone. And the interesting thing is the failure rate of placing pancreatic stents was 20% in this group, which means some participants failed more than that. And despite that, intent to treat, meaning they tried to place a stent and failed, even by intent to treat, the arm with intended pancreatic stent placement still did better. So in spite of the negative effects. So what I'm going to show you is a little bit of detail and of how to do this. This is something I adopted 30 years ago and have always been dedicated to. Now, clearly, when you can place a guide wire to the tail, as you see here, you can use any kind of stent, short, long. We actually developed a very flexible kind of polyurethane stent, and I have no conflict of interest whatsoever. It's called by Hobbs Medical. Not even had a free dinner from them, so I have no conflict of interest. Very small company, but very flexible and non-injurious to the pancreas, and they tend to fall out. I mean, that's my preference. I'm not saying, anything novel that, that's the only way to go. So let's see if this is playing. What I wanted to show you was sort of how we activate the video on this. I'm not, there we go. Okay. And then I'm going to skip through it. Point is, what is a high-risk ERCP? This is an obese young woman with a bile leak post-cholecystectomy and very small ducts. So I'm going to show you the approach I've developed. This is high risk in my book: small ducts, normal pancreas, and this is sort of how I did the first ERCP in the live course in Delhi, is intentionally go for the pancreatic duct with a small wire to secure it so that we know we can get a stent in it. And then, and this is a 018 wire, which we're very atypical in that we use that, and I'll show you one of the reasons why. And then find the bile duct, which can be challenging, but the double wire will often make it much easier by straightening and separating ducts. That technique was described by Jacques Deviere first many years ago. And then without having to manipulate more, eventually find the bile duct. And then maybe I'll skip ahead here. But the point is then, once you're in the bile duct, before you do any biliary therapy, you place the pancreatic stent before. And that way you've guaranteed safety. And when we teach fellows, the hardest thing to teach them is to safely access and stent a small pancreatic duct. There's many ways to access the bile duct, but there's only one way to safely access the pancreas, which is with a careful guide wire. And so this is sort of a preemptive style of ERCP, and then we go on to place the biliary stent. So it's a little extreme, but it's anticipating problems. So that's with a wire to the tail, but with an ANSA loop duct like this, passing a standard wire can dissect, and I'll show you a sad case in a minute. And the way we actually published this 20 years ago, using a tiny wire and knuckling the wire, just placing a short stent will do that. And this is a patient in whom we're intending biliary sphincterotomy, again, young woman, sort of type 2 sphincter of Oddi dysfunction, small papilla, small ducts. This is a disaster waiting to happen if you're not exquisitely careful. And the MRCP showed that she has a very tight ANSA loop duct. So with just the smallest amount of knuckled wire in the pancreas, and really this is the only type of wire that we found that is really stable. The slippery hybrid wires just either go through a side branch or fall out. And then in this case, once the pancreatic stent is placed, we actually use a gentle guide wire to find the bile duct. But it's preemptive, careful anticipation of risk and prevention of risk. And this is the kind of ampulla where you get into big trouble if you start doing advanced techniques. At any rate, this is a very sad case that I've actually seen several of now. I was asked to testify in a wrongful death lawsuit for the defense, which I would, because they did guide wire cannulation by shooting a wire in the direction of what looked like the bile duct. Only then they realized it didn't travel quite right, so they injected a little contrast, and it was actually transecting an ANSA loop. The patient was transferred to a tertiary center but died, and she was 35 years old with a bile duct stone. So, there's a lot of guide wires are a hazard, and I'm going to show you that now. And even Joe Munzer, I have enormous regard for, a brilliant researcher. It took me a year to convince him of this because he didn't believe it. And then I showed him the data, and now he believes it. He went to the NIH 3 times to get patients with a guide wire in the pancreas included in the SVI trial, but they wouldn't accept it. And again, it's because but the data are there. And the point is just putting a guide wire in the pancreas once in a susceptible patient, healthy pancreas, can dramatically elevate the risk. And here's the data. A brilliant Chinese study is very similar to the studies I've done, only I will say more comprehensive and better. And they separated pancreatic deep wire pass from contrast, and this is their multivariable model of posterior CV pancreatitis. Deep wire pass was significant. Contrast injection was not. And this is a list of their risk factors. A terrific Japanese study where they prospectively studied 800 patients undergoing guide wire cannulation in intact papilla, and the only risk they found was deep wire insertion in the pancreas, not PD opacification. So that's why our style, as I showed you, is a little bit of contrast, see where it's going. You're not going to hurt anything with that. You're more likely to hurt it with a wire passed blindly. And just though, the double wire technique, which we use all the time, if you don't follow it with a pancreatic stent, is very risky, 25% pancreatitis, but if you follow it with a pancreatic stent, it virtually eliminates risk. So that's why I thought it would have been a great entry criteria. Joe tried to get it in the SVI trial, but it goes contrary to thinking. So PD wire is a risk, it should be followed by a PD stent. And that's the guidelines, the ASG guidelines now. And it's, again, everything's relative. If it's a young woman, small ducts, high healthy pancreas, one wire pass. If it's a 90-year-old with obstructed pancreatic duct with pancreatic cancer, you probably can't hurt that patient. They don't need a pancreatic stent. Perforations used to be medical surgical, but delayed recognition leads to very poor outcomes. We've known that for years. Really good study from Indiana from 25 years ago. Sadly, this is a case that, not sure why it's not quite showing, but doesn't matter. This ERCP by a very experienced endoscopist just a couple of weeks ago in Minneapolis, removing stones, and you can see what might be the problem in the right screen is the straightened endoscope. And when you pull out a stone, the back of the scope can traumatize the duodenum. And then you see here, you're starting to see retroperitoneal gas. And at the final film, you see not only retroperitoneal gas, but extravasated contrast. But this endoscopist said, well, I think there's a defect on the back wall, but I don't see any bad thing on the other side of it. And admitted the patient, said, and didn't do anything about it. And what happened was she got severe retroperitoneal abscess, decompensated, had to go to emergency surgery. So, having cost a fair number of these myself, and this is one of them, I'll say this was the worst duodenal perforation I think I've ever caused. Here's the lumen, here's the perforation, bigger, and it's a very elderly, fragile lady, back wall of the duodenum. This is and it's from the scope. And she had a stricture downstream. It's a long story. But what do you do about it? Recognize it. And in this case, it's too big for an over-the-scope clip. Serial clips, cap fitted. You can see the free air here at the end. We put about 8 clips on it and injected contrast to make sure the leak was closed, NJ tube, and she actually did fine. So very important to recognize them. And here's a sphincterotomy perforation. 50-year-old with a hilar mass, again, extremely experienced endoscopist. And the point of this isn't how you stent hilar tumors or what you do with them. It's that this was the ERCP in the middle, and this is the final film. And this endoscopist didn't recognize anything. Can anybody here tell me what they see on this film? Where? Right, so you're seeing an outline of the right kidney. So this is the most dramatic. And wasn't recognized. Patient developed retroperitoneal abscess, and it was a 50-year-old with a completely resectable hilar cholangiocarcinoma, delayed surgery by 3 months. R0 resection, but the patient died of metastases. Probably, it had serious consequences. Now, I've caused plenty of these. Here's one again. I'm doing this. It doesn't look like a big sphincterotomy with small duct. And as we're passing the wire through a hilar tumor, you see this big contrast leak and gas. So any ideas what to do about it? Well, we have a way to treat that now, and it's a fully covered self-expandable metal stent. We use the anchored type, the viable, but there's many choices. And Guru Trikanathan and our group published this series of 12. It works pretty much infallibly, with one exception that it can cause pancreatitis. And we did subsequently have one patient where without a pancreatic stent with the biliary sphincterotomy where the stent closed the perforation but caused pretty severe pancreatitis. But that being said, in most cases, the way to go. So there's 4 types of perforation. Lumen is through over the scope clip, fully covered metal stent for sphincterotomy. If it's a guide wire perforation, stent beyond the duct, especially in the pancreas, or beyond the leak, I'm sorry. So endoscopic perforation should be routinely looked for. How much of a problem are duodenoscope transmitted infections? Not sure. I just want to skip over that. I think the problem has been solved. We toured the disinfection lab here. It's exquisite. Have you seen any scope transmitted infections here in the last year or two? Right. Right. So it's a problem that I think was severe a number of years ago. It's recognized. Personally, you have to question whether it's worth disposable scopes. And I think all of us feel it's unnecessary, plus which the performance of the endoscope is critical in preventing other complications. So, if a disposable scope doesn't perform well, it'll create other problems. And I thought I'd throw in a little about bleeding after sphincterotomy. Somebody with a pancreatic stent, biliary sphincterotomy, who's come in later with fresh hemorrhage. We looked at risk factors in the New England Journal study. The number one risk factor, and Michelle Anderson gave a great talk on this at the course in Delhi. But the number one risk factor for bleeding is starting anticoagulation within 3 days post-sphincterotomy. And then there are others as well. So it does, and it have to weigh risk benefit to restart anticoagulation. But once it happens, you think you still want to start with injection, especially on the left wall. You want to be very careful about the right wall of the sphincterotomy. You want to be careful but clips, but again, left wall clearly separate from pancreatic orifice, probably okay. Be very careful with bipolar coagulation. You can use fully covered metal stents for bleeding, but again, beware of causing pancreatitis, especially with small ducts and small sphincterotomies. And this is a case, in this case, there was a pancreatic stent in place, which was very valuable because the bleeding was right next to the pancreatic orifice. So with the pancreatic stent there, we were able to isolate the vessel and flip it. So we covered duodenoscope infections. The number one way to avoid complications is avoid equivocally indicated or ineffectively done ERCPs. So there may be an indication, but maybe the setting or the endoscopist is not ideal. You already saw in the first case, the dubious indication, disastrous results. And to quote the venerable Peter Cotton, the ERCP is most dangerous for those who need it least. And it's critical to track complications, but remember the incentive to track them is the same as reporting every dollar of cash income on tax form. So, and I must say in the US, we're very spotty about reporting complications. I'll stop there. Thanks a lot.
Any questions? I'll start probably, Marty, with two things about this Joseph Elman's study in Lancet. Why is it that when they they couldn't get into the pancreatic duct also? In that group also, the complication, they didn't increase? Because I remember your study, you reported a series of very severe complications with the pancreatic
Right.
duct.
So that's what is astounding about his study, because there was a 20% failure rate of attempting, which is what we've worked for decades to learn how to not do, which we published, with that tiny wire technique. Is basically no failures if you can find the pancreatic duct. But despite all those failures, the intent to treat group replacing pancreatic stents still did better than the no stent group, because the protective effect of pancreatic stents is that great. I think if they had a 95%, with some Asian studies, by the way, with 98% successful pancreatic stent placement, so I think what it says is that it behooves endoscopists to really learn how to place pancreatic stents carefully and effectively. And if you can do that, frankly, the protective effect would have been much greater. And but even with all those failures, it was still better than just leaving the
So that
pancreatic
gets me to the
stent
next
out.
question, because cell therapy is better, and generally we say you put pancreatic stents only for high-risk patients. The medicine for all the people plus pancreatic. So now could we say that use routinely for everybody?
No,
No?
no. I mean, if it's an elderly patient with a bile duct stone and you get right into the bile duct and, no problem, sure, no. But I think the awareness of a combination of patient risk and procedure risk, and what I hear over and over again is, well, I'll put the wire in the pancreas 3 times, but if it's 4 times, I'll put a stent in. And my analogy to that is, well, if it's a young woman with healthy pancreas, small ducts, 1 pass is probably enough. But if it's a 90-year-old with pancreatic cancer, so you want to modulate the patient, the probability of putting in a stent, but anticipate risk. And this is where, sadly, we saw a patient yesterday who was in the ICU for a month with a single wire pass into the pancreas, young woman with bile duct stones, and got NSAIDs. That's the kind of patient where personally, now with his study, I think it really enables us to go back to, let's all learn how to do this effectively, carefully. And there have been studies from Japan showing all risk ERCP, placing pancreatic stents, still reduce the risk, but you have to be really, really good at pancreatic stent placement. So it's like everything, it's kind of a weigh the risk. Anyway.
Questions? Yeah.
Thank you, Professor Martin. So the question remains, ever since your paper was published in 1996, the risk of pancreatitis is quite variable, but still in the best of the best centers, so the the risk of pancreatitis, we have been able to bring it down to less 3 to 5% in the best of the units, in low risk, average risk patients. So is there any possibility to bring it further down?
yeah.
Because in spite of intervention, like we have rectal endomethacin and there's rectal NSAIDs and pancreatic stent, but we are not able to achieve less than 1%. So is there any role of US guided procedures at the upfront to reduce the risk of pancreatitis?
Yeah, sure. The problem is, you have extraordinary expertise in US guided procedures. That's not widely available. ERCP is everywhere. First of all, our center, I actually look at my own data, and we're 1.5% pancreatitis, and actually none of them were in intact papilla access for me last year. They were all pancreatic endotherapy or ampulectomy. And Rajiv we were talking about this too, his rate is 1.5%. I think if you do a preemptive pancreatic prophylaxis approach, you can pretty much approach 0. And as I said, in my case, it's always aggressive pancreatic therapy, even in chronic pancreatitis or ampulectomy where the stent fell out. And really, yeah, Rajiv, you were going to say. I think we can achieve that, and I think we have to a certain degree. I think we can do better than 3 to 5% in average risk patients. We can do better.
Marty, besides the rectal endomethacin and the stent, where do you place the role of aggressive hydration?
Yeah.
Is that something you believe
Yeah,
in?
there's data there, and it's recommended. Don't know how effective it is. I think it notches it down, but it's not going to. What it really does doesn't prevent it. It reduces the severity. And the worst thing is to send somebody home like that first patient I showed you, and then they come back, you know, hypovolemic with multi-organ failure. And we have pretty good data that early hydration will reduce the severity. Yep.
I have a question for the residents. I'm going to ask on behalf of them. So they're a pretty good endoscopists. They're all trained by these experts. Let's assume it's a high-risk patient, small doc, maybe a small stone, positive IOC. They cannulate without getting into the PD. No wire in the PD. They cannulate. They've done it. Do they still need to spend time? So the reason I want you all to understand is this question gets asked all the time. So if it's a straightforward cannulation of the bile duct, you've achieved what you need to do, then don't spend time mucking around trying to get into the PD.
Right, but it depends. Well, yeah, but wait a minute. Tell me why, who you're doing it at and why. So I showed you the bile leak, the video I showed you. Young woman with small ducts and a bile leak. So what I do, and I did this in the first live course case in Delhi, is we intentionally go into the pancreatic duct to put a little wire in it, then do the bile duct, then stent it, because young woman with a small duct and a bile leak and a small papilla, and you're going to put a big stent in there, is high risk. And so it's a little different. It's just, don't just try for the bile duct. And
But I think that's where the question comes.
but do you go back and find? No.
If you've gotten in and you've done it first time clean, I don't know if you should spend time, because going back to your own paper, the failure of attempting to place a stent, you know, it's a small group, but 66% risk of complications.
Yeah, but on the other hand, it's what is high risk, and that's, I think, where the confusion is. The patient we saw yesterday had one deep PD wire pass. They pull out, go into the bile duct for a bile duct stone. No contrast in the PD. You tell me, is that high risk?
Once you get a wire, I think you should leave the access.
Okay, but that's not what's been taught. Is as long as you poke wires around and you don't inject contrast into the PD, it's not high risk. There you go. Thank you,
So,
Dr.
Marty,
Anderson.
just to change the scenario a bit, you get into the bile duct, get the stone out. Now you have either post-sphincterotomy bleed or perf, and you're looking to put a metallic stent.
There we go.
Now,
Yes.
go to PD.
Yeah, because we actually, with expert colleagues, one fatal small duct, bile duct stone, elderly person, took the stone out, but there was a sphincterotomy perforation, put in a viable covered metal stent, and she died of posterior CV pancreatitis. So, you know, that's an anecdote, but yes, and it all depends. If you have a huge sphincterotomy in an old person and there's a perf, and you think the pancreatic duct is free and clear, I would leave it.
And last question again for the trainees. What do you say about injecting contrast when you get into PD? Because many people I see are very reluctant to inject contrast.
Yeah.
The wire may be going anywhere.
Right. Well, I showed you a fatal perforation, and sadly, one of those occurred at my institution with, many years ago. Wire went right through an ANSA loop. And even though eventually got a stent past it, it was too late. Damage was done. And a little bit of contrast to outline where the pancreatic duct, that's how I start all the RCP, a little bit of contrast. Unless, if the cannula pops into the bile duct, obviously, which, you can usually feel with biliary obstruction, that's different. But then a little contrast doesn't hurt there. Little contrast doesn't hurt. The guide wire hurts. And that's the one thing can really hurt. And I showed you, hopefully, data, cases, anecdotes, and at least what I have evolved. And to answer your question, we look at our pancreatitis rate is under 2%, but we do an extraordinary amount of endotherapy of pancreatic disease, Devisum, and even sphincterotomy for idiopathic pancreatitis, which is very controversial. Anyway, I should stop. You've got more great talks to go.
So, he can talk forever because he's very passionate about it. I think that's the passion you need to inculcate. It's my pleasure to introduce my friend and not quite, I think she's a colleague because we work together on ASG. Michelle Anderson, she spent her career at University of Michigan, and those who watch football, it's the Go Blue, and from there she decided to go brown and went to Arizona, the desert. She feels right at home today. No, we are not. So Michelle Anderson is a therapeutic endoscopist trained in EUS, ERCP, has done a lot of work, done a lot of research on pancreatic cyst, pancreatic cancer pathways. She's one of those rare people who also did quite a bit of basic science research, and I was trying hard to get my head wrapped around us, and together we worked in development of the CAPER program for pancreatic research with the trainees. And I am glad that she's here at Hyderabad, and she will be talking about chronic pancreatitis. Is it just all about endotherapy, or is there more to it?
No. Everyone get up and stretch. You guys must be so stiff. You've been sitting, you're waiting for us for like an hour, right? Stand up, stretch. Come on, 2 seconds. Everybody up, wake up. I've seen lots of yawning. There we go. Well done. Okay, so I can advance. This is the pointer. Here. Next. So for the pointer. And can they see my? Oh, no. Okay, so it's got to be that. Okay, great. Okay, so so we're going to talk about chronic pancreatitis. Spoiler alert, it's not all about endotherapy, even though for many of us that's our favorite thing to do, and we want to do it all day, every day. But down with this one. Good. So we're going to talk today about several indications for endoscopic therapy in chronic pancreatitis, including biliary obstruction, leaks, and for patients that have pain, probably the most common indications that we do ERCP in this patient population. We could spend time talking about drainage for chronic pancreatitis complications. That's not going to fit in a 30-minute talk or less, so we're going to not talk about that today. I think Dr. Attam's going to talk a little bit about dealing with pancreatic fluid collections. So all of this is going to be case-based. Here's our first case. This is a 57-year-old, which of the following patients is most likely to benefit from ERCP? So this is 5 different patients. We're going to come back to this at the end. This is an American board style question. I don't know if you guys take certifying boards or not, but this is definitely what we would see on an American board exam. A 57-year-old male with alcoholic chronic pancreatitis, a dilated PD at 5 millimeters, and a normal hemoglobin A1C. A 62-year-old diabetic male with a 1.8 centimeter stone in the tail of the pancreas and chronic daily pain. A 43-year-old female with 2 episodes of idiopathic acute pancreatitis but a normal MRCP. A 34-year-old female with episodic pain, 2 body of the pancreas stones measuring 5 and 6 millimeters, and dilation of the pancreatic duct upstream in the tail of the pancreas. And then finally, a 70-year-old male with painless calcific chronic pancreatitis with a CBD of 8 millimeters and an alkaline phosphatase of 200. That's normal in our labs. So really what you're looking for here, what's that? Yeah, well, if somebody wants to go out on a limb and pick one of these now, we're going to come back to this at the end. D, like dog? That's right. Very good. But we will come back to that exact case at the end. Okay, our next one is a 55-year-old male with alcoholic chronic pancreatitis who presents with jaundice. He has been abstinent for more than 5 years from alcohol. Bilirubin is 3.7, alk phos is 477, and his CT shows chronic calcific pancreatitis with a bile duct that's 10 millimeters and an obvious CBD stricture. EUS is done to exclude a mass in the head of the pancreas, and that's negative. So who wants to do ERCP in this patient? Raise your hand. Come on, guys. Everybody should be raising their hand. Okay, so that is what we do. And we'll talk about why in a minute. So this is the patient's first ERCP, and what you can appreciate is a stricture in the intrapancreatic portion of the distal common bile duct, right? You can even see the calcifications in the patient's pancreas, right, around it. So I do an ERCP, and I put in 3 stents the first time. I bring him back. He still has the stricture. I put in 5 stents the second time. I bring him back for his third ERCP, and we see a little bit better, but still not normal. That's a really raggedy looking thing. So what are we going to do next? Send the patient to surgery, right? No, we put a covered stent in, right? Which we probably should have done earlier, but this case is actually probably 10 years old, and there wasn't a lot of data yet on using covered stents to treat these types of strictures. And then we bring him back, and now we have a beautiful bile duct, and the patient did well. So what do we know about bile duct strictures and treating them in the setting of chronic pancreatitis? Some of you were hesitant to raise your hand originally because the patient probably didn't have pain, and you were thinking, oh, why am I doing this? But in fact, we know that in patients that have ducts greater than 12 millimeters or an alkaline phosphatase that's more than 3 times the upper limit of normal, those patients are at risk for secondary cirrhosis from the chronic obstruction, right? So those patients you treat even if they don't have pain. We know from case series that we're successful doing this in about 60 to 85% of the patients. We do better if there's not already calcium in the gland of the pancreas. So this patient didn't necessarily portend well for a good outcome, but he did do well. We're typically treating these with dilation, balloon dilation, and then a placement of a covered metal stent or multiple plastic stents in parallel. Keep in mind that if we fail, surgery is still an option, right? The patient can still have bypass surgery. So when we look at the data that compares covered metal stents versus multiple plastic stents, there is quite a bit of data out there. 7 randomized controlled trials to date, including a large randomized controlled trial from Europe and Asia, 2 meta-analyses, and these studies show no difference in stricture resolution, no difference in stricture recurrence, and no difference in serious adverse events when you weigh fully covered versus multiple plastic stents. What fully covered metal stents do is it lets us do this quicker with fewer ERCPs, right? We're reducing the number of times that we have to bring the patient back. And it's that reason that has made both the ACG and the ESGE, as well as a new guideline that's going to come up from the ASGE soon, state that either approach is acceptable, multiple plastic versus covered. But a recent guideline that was led by Dr. El Munzer and the Quality Committee on management of biliary strictures, both malignant and benign. Got a question? Oh, for this paper. Oh, yeah. Nice. But so this guideline that was just published last year from ACG said that in patients with extrahepatic strictures due to the benign conditions, that they recommend fully covered over multiple plastic stents in parallel. And that's because of the decreased number of ERCPs that are needed. Okay, our next case is a 52-year-old female who has alcoholic chronic pancreatitis, and she presents with dyspnea. This is her chest x-ray in the emergency department. You can see that her left lung is almost completely whited out. And this is her CT scan, and you can see a large pleural effusion on the left. Going down, we see some ascites down here. She's probably got some perisplenic varices as well. This is her ERCP, and what you can see here is a disruption in her duct, and the contrast literally tracked straight up into her lung. We could watch it during the ERCP go up there. You got to be careful in those cases because they can have secondary pulmonary edema from the contrast going up around the lung. So minor injections in this setting. So to treat this patient, we, of course, did wire placement deeply beyond the level of the disruption. And you can appreciate this is a 7 French stent that we placed that bridges that disruption. And we brought her back 4 weeks later. This is her repeat chest x-ray. We also did a CT scan, and she had complete resolution in that leak, and she did well. So in terms of endoscopic therapy for thoracopancreatic fistulas, the best or the most comprehensive data is in this systematic review. This was 75 case reports, 19 case series, over 100 patients. They found that the most common site for the leak to occur was in the body of the pancreas, as was the case in our patient. Not surprisingly, the most common place that the effusion goes is into the left lung. It can also become pancreatic ascites, or it can go into the right lung less commonly. The most common symptom that these patients present with is dyspnea, and endoscopic therapy is successful about 42% of the time. When we look at the factors that are associated with success when we treat endoscopically, as we did in this case with the stent, what we find is that being able to see that there's an actual fistula on the ERCP and the injection, that's associated with a higher likelihood of success. Placing that PD stent across the point of disruption, the highest predictor of success, and then use of a pancreatic sphincterotomy also associated with success. When the patients have PD stones, that lowers the likelihood of the endoscopic therapy being effective, which makes sense, right? Even if you stent it, you've blocked the flow of the pancreatic juice. You really haven't resolved the entire problem that's driving the pancreatic leak. So our next case study is a 34-year-old female with a history of symptomatic choledocholithiasis postpartum. This is actually the first case that somebody recommended the ERCP in. She had a cholecystectomy, and at the time she had ERCP with a common bile duct stone extracted. That was about a year ago. She developed diabetes post-pregnancy, and that was treated with liraglutide. She presents to GI with episodic epigastric pain. She's not on chronic opioids at the time of presentation. She has a normal comprehensive metabolic profile, and she has a normal amylase and lipase at that visit. So what you can see here, I think I got to make this run 1 second. You can see the problem we ran into here, Marty. Hard to start it. Yeah, it's so tiny on the presenter view. Thank you. Your young eyes. Good job. Okay, so this is the MRCP, and you can see the pointer is actually pointing out a stone there at the head-neck junction. There's another larger stone in the body of the pancreas, and then there's 2 smaller ones out in the tail of the pancreas. So, of course, we're going to do ERCP in this setting, as you guys correctly noted. So this is the patient's initial injection. You can see a very dilated main pancreatic duct. We've got the filling defects that fit with the MRCP findings here, and some smaller stones here that are in a conglomerate amount in the head of the pancreas. So what I didn't show you, sorry. So there's also a stricture, a very tight, short stricture right here that's probably contributing to the dilation and the stone development. You got to deal with this before you can deal with the stones, right? So in the next film, you can see that we've done a balloon dilation with an 8-millimeter dilating balloon. In terms of safety, we can talk about that in the question and answer. We can go as large as the diameter of the pancreatic duct, right? So I knew we had to get out these stone fragments that we're going to show in just a minute. So I want to give myself the best chance of doing that. So I've gone with this larger balloon to do the dilation. And at my center, we don't have S-wall. Let me stop for a second. This place is so impressive. You guys, I hope you appreciate, especially the trainees, the wealth of resources that you have. I mean, I'm from the Mayo Clinic, and they joke around how much money we have all the time. We joked around about it today. But you guys really have the best equipment and the best technology here, and that's such a blessing. So I don't have S-wall, but I do have spyglass with EHL. And I might... Oh, this is just an image showing the spyglass, the cholangioscope coming out to the end of where the first set of stones are that we're dealing with. Oh, and it's running. Okay. So you can see this is the main pancreatic duct. We've got a large stone in here, and we've got the EHL probe. And we do a great job of busting these up. These are very hard stones. That's why they're not amenable to standard techniques that you might use with gall stones in the bile duct. But the EHL probe is able to fracture these up. And I'm going to jump ahead. And so after we do that and we break up, we spend probably an hour breaking up those 3 different stones, which as well would take less time to break those up. But you can see some of the fragments coming out that we extract with the balloon at the end. And then we're going to see much bigger pieces coming out now. And this lady did very well after we got rid of all those stones. So in terms of endoscopic therapy for PD stones and chronic pancreatitis, I've noted here a systematic review and meta-analysis, quite large, published a couple years ago, 16 different studies, almost 400 patients. In this study, they used both EHL and laser lithotripsy, or a combination of the same, to treat the stones. And what they saw was technical success, which they defined as clearance of the stones, of more than 3/4 of the patients. They had clinical success, which was defined as pain reduction in only 66.5% of patients, telling us that it's not all about obstruction, right? We're going to come back to that in a minute. So you've seen technical success, but the patient hasn't gotten significantly better. One should keep in mind that these approaches in these patient populations have high risk. There was a pooled adverse event rate of almost 15%, including 7% post-DRCP pancreatitis, and almost 5% incidence of perforation. Risk factors for failure to treat these stones endoscopically are multiple stones, strictures, impacted stones, stones greater than 17 millimeters in size, and difficulty in cannulating the pancreatic duct. So, all these different cases I've shown you are wow, cool, we get to do all this stuff, right? And so as therapeutic endoscopists, I think we tend to think of ourselves as a hammer and all of these different entities as nails. And I would put to you that that is in fact not the case, and that the pancreas is more like a delicate egg. And so when we apply our hammer, that not good things happen. So here's where I'm going to talk about the fact that pain in chronic pancreatitis is actually multifactorial, right? Sometimes it's mechanical, it's obstructive, but often it's not. It's inflammation, changes in cytokines. A big area that now has been well established is that there's neural remodeling in these patients, right? So we can make everything better. We can take out all the stones, we can treat all the strictures, we can treat necrosis, and the patient still has pain. And we think that that is likely due to remodeling, both at the peripheral nerves, the central nervous system, and the brain. Quick note about malabsorption. So malabsorption, or pancreatic exocrine insufficiency, I do believe can cause pain in some of these patients. And the reason I think that that happens is because they maldigest, they get production of gas. What do our intestines feel, right? They don't feel when we cauterize or remove polyps, they feel distension. They have pressure receptors. And so if that patient is experiencing pain and has symptoms of malabsorption, be aware of that, think about that, and treat that, because that can help with underlying pain. So one of the studies that I was honored to participate in with Dr. Gouda is the NAPS2 trial. And during that trial, we learned that pain in chronic pancreatitis is a continuum. We gave patients 5 different choices of describing their pain, and 20% of the patients couldn't pick one of those 5 descriptions. So it's a really complex thing. We also learned that pain impacts every facet of their life, their functioning, their ability to go to school, their well-being, their psychological health. So it's a very complex thing. And then one important thing that we also learned was that the temporal nature of the pain, meaning the frequency, I'll tell you more about that in a second, had significant impacts on quality of life in both the physical and the psychological domains. So what I mean by that is that a patient that experiences even a low level of pain, but with no relief, that patient's quality of life is more significantly impacted than somebody that has 2 episodes of severe pain twice a year. Much greater effect, and that was something that we didn't really appreciate. We always think about pain on a scale of 1 to 10, and we tend to think about people that have a 10 as having terrible quality of life, when in fact that's not it. If you suffer with pain day after day after day after day, that's a miserable existence. And that's something that we learned from that trial. Another important point to note, and Dr. Freeman and I were actually talking about this on the plane here, is that imaging results don't correlate with actual experience of the patient or their pain. Meaning we see patients that have, and I know you guys see this here, elderly patients that come in with chronic pancreatitis, calcium in their gland, a big dilated duct, multiple stones, and they have no pain, right? Who's seen patients like that in your clinic? Yep. And so this study, which was a corollary of that NAPS2 study, the validation part of it actually, showed that none of those findings, calcium, atrophy, PD dilation, none of them correlated with clinical symptoms. The only one that did was active inflammation on the cross-sectional imaging. So following the NAPS study, we came out with a white paper when experts met together at Pancreas Fest, a national U.S. meeting that was sponsored by the NIH, and we came up with therapy recommendations in chronic pancreatitis, and I quickly want to go over those with you. First was that medical therapy should be first line, so behavior modification like alcohol and smoking cessation, pain medications in a tiered effect, reserving opioids till the very end, enzyme replacements, and maybe antioxidant therapies, all first line. Endoscopic therapy can be beneficial in certain settings, such as pancreatic duct dilation or stones, in the right clinical setting, like the cases I showed you today. And then surgery is indicated when medical and or endoscopic therapy fails. Surgery is preferred over endoscopic therapy if there's a high stone burden, especially if those stones are in the body or tail or there's associated strictures. So I put this up because that paper that we wrote was published in 2016. This is a guideline from the ACG that came out in 2020, and you will see that almost nothing has changed from the 2016 recommendations. They recommend surgery over endoscopic therapy for long-term pain relief due to the data showing sustained benefit in that setting when endoscopic approaches and medical therapy have failed. They recommended considering the use of antioxidant therapies for chronic pancreatitis pain. I think a lot of that data is from here, right? From India. Yeah, I use them actually. We do not suggest the use of pancreatic enzymes solely for pain control, which I don't disagree with. And they suggest considering celiac plexus block for pain and chronic pancreatitis. This is not something I do. I think the data is extremely weak. I think the chance of a complication is actually more likely than the chance of benefiting the patient, but they said suggest, consider. More recommendations on doing endoscopic therapy in this patient population. They caution against doing it in patients that are still actively drinking or smoking, which I agree as well. We talked about using opioids only when other therapies have been exhausted. There's actually a specific recommendation for total pancreatectomy with auto islet cell transplantation, that should be reserved for highly select patients. And we might talk about that in the question and answer period, and I'm sure Dr. Freeman would be the person to answer those questions. And then experimental treatment should be limited to research settings. And then this also correlates well with the ESGE guidelines. And I just want to point out a couple of additional points that they make in the European Society. And you, Professor Reddy, you were part of this group, right? So they recommend actually Eswal as first-line therapy for main pancreatic duct stones with obstruction. A corollary of that is that they said consider EHL if you don't have Eswal, like I don't. They also agree that patients should stop smoking and drinking before you undertake endoscopic therapy. And then they recommend that if the patient has large stones, especially if those are radioopaque, those are ideal for Eswal, right? And if they're radiolucent or small, those are amenable to ERCP-related therapy. The last point is one that's not in any of the other guidelines, and they recommended a use of a 10 French plastic stent for a period of 1 year to treat symptomatic main pancreatic duct stones changing the stent at least every 6 months or when the patient shows evidence that the stent is malfunctioning, that it's plugging up. So that's a new one. That's a difference from the other guidelines. So I'll close with these are my last 2 slides. I've been asked about endoscopic therapy and pancreatitis and when should we stop? Specifically, when is enough is enough. When the indication is appropriate, you go until the job is done, typically up to a year or more. And patients need to know that going into it, right? This is a commitment that they're making. This is a contract that they're making with you. Are you going to be able to follow through with me for a year if we're going to take this on endoscopically? When the indication is inappropriate, and this is something that Dr. Freeman really brought home in his talk, don't even start, right? Don't be using these therapies in patients that are unlikely to benefit and likely to gain harm. So I've learned so much about India since I've been here, and I'm very curious about other cultures and other religions. I'm sure everybody in the audience knows this is an Om sign, but it made me think about that principle about always doing good and avoiding harm as a center tenet of your religion. And I think that applies in this setting as well. So I'll stop there and take any questions. Thanks.
Thank you, Michelle, for that very nice talk. Just 1 or 2 comments regarding, I think this slide which you put up about what Mel Wilcox study was, that imaging doesn't have core. Very interesting slide, and in a large practice, a huge number of things that don't have any pain. So we actually looked at this fundamental question whether the relief of pain which patients are getting with extracorporeal shock wave or EHL or removal of the stone, is it just related to decreasing the obstruction, or is there any other factor? Because if you look at all the basis for this came from an old study in cats where they increased the pancreatic duct pressure, relieved the pressure. That was the basis. Nobody really established a connection between pain and pancreatic interstitial duct pressures. Few old surgical studies, again, not very well done. So we had a hypothesis that is not just duct obstruction, but neuropathy, which is very important or more important. And of course, neuropathy we've been treating with this neuropathic agents and so on, especially inflammation also. So
like gabapentin and things, drugs like that.
So in fact, if you look at the pathology of these glands very carefully, most of them have hypertrophic bare nerve endings. And of course, we have the receptors which are also there. So we had another hypothesis that with extracorporeal shock wave, we're actually hitting on these nerves. And then causing, because what surgeons also do is when they do a pancreatic or jejunostomy, the older drainage techniques now replaced with resection of like the phrase technique, where the head where you have the fundamental pain pacemaker is gone. So we have now embarked on a small study with patients who don't have maybe ductal stones, who don't have ductal dilatation, only pain, and then do low-grade extracorporeal, not to break the stones, but to induce neuropathic damage. And now we have a good series of patients followed up for 6 months who never had resolution of the pain with analgesics, with new pregabalin and so on. But with this technique, they absolutely no pain for last 6 months. We have a series of patients now. We intend to follow them longer.
Wow.
And then this is very interesting. And of course, we have to do a sham study to show it's really effective. But the first thing was a proof of concept study. So I think extracorporeal shockwave has 2 different things. One is clearance of the stones. And second is maybe there's some effect on the neuropathic part of the pain also.
Yeah, I mean, I think that's really interesting. Are the patients that you're doing that on, do they have parenchymal calcification?
Yeah, so in this group, we have 2 patients, those who don't have calcification. So we actually measure the head by various means to focus where we have to give this extracorporeal. The second are those who have parenchymal or ductular calcification, which are not causing main ductal block, where it's easy to target this.
Do you see a difference in the 2 groups?
No, there's a difference.
Same.
Both are similar. And then we have to use 5 different spots, low grade, not the 5,000 units.
Yeah.
With much low.
Yeah. I mean, I think that that's a really interesting concept. And I think the reason I asked you about the parenchymal calcifications is because I've always wondered if the patients that have pain with parenchymal calcifications, but not main pancreatic duct, if they have like tertiary branch obstruction and calcification. So you could further theorize that what you're treating, at least in the patients with the parenchymal calcifications, is microducts.
Yeah, microducts clearing. But majority of the patients
Don't have it, right? Which is why it's interesting. I would expect, though, even with what you're saying, that there would be some portion that are not going to respond due to the central nervous system remodeling.
So once, again, it's very important. After 5 years, many of them have central neuroplasticity. And once they develop neuron, nothing can help them. In fact, even if you remove the pancreas, they continue to have pain.
Yeah.
These are, so I think we'll have to do this very quickly before they develop as neuroplasticity of the central part.
Well, and that's why I wonder if Dr. Freeman might comment on the recommendation about TPIAT, because my concern in waiting till everything else is exhausted to do that technique is that you have had massive central nervous system remodeling, and those patients are not likely to respond.
Yeah, it's interesting. Couple of things. So I'm at the center where TPIT was invented in 1977, and they've done over 800 cases, but now we have a huge prospective, multi-center, NIH-funded study by Melina Bellin et al. 240 patients at 12 centers followed for 2 years. And the news flash is, first of all, kids do way better than adults. And the most miraculous results are kids with hereditary pancreatitis. It really is their quality of life, we published this years ago, is to absolutely terrible to completely normal.
Amazing.
For many reasons. The other really baffling newsflash is that and it's the analyses are just going on, but duration of disease and pain do not predict outcome of TPIAT. And that is hard to understand, but I think it to a degree negates the concept that after a few years it's all centralized. It's so we'll see. I mean,
So in your mind, it's not too late ever.
well, I don't know about that. I mean, there are data that earlier is better for endocrine function.
Yeah, for diabetic protection.
And there's no question what are poor predictors is narcotic use and smoking ahead of time.
Yep.
So, but we'll see. Those data are being grinded out. But it's, anyway, it's an interesting area.
All right, we'll wrap up the session soon. We have our next speaker is Dr. Rajiv Atham. He's a dear friend, colleague. He's like my brother because he trained after me at Minneapolis with the same mentor. Except he's the better looking. He does better endoscopy, and he's going to talk about what to do in pancreatitis. We all deal with situations of duct disruption. So he's done a lot of work, and he's going to talk about it. So but every sibling gets the better of the other brother. So I invited him to give this talk, but I also invited his wife to be here. So we'll see how he does. Is it possible? I have to
Got it? I don't need audio. Yeah. This is. Okay, good afternoon, everybody. Thank you, Dr. Reddy. Thank you, Nalini, for having me here. It's just been an amazing experience. There's just like, thank you. So Nalini asked me to speak on disconnected pancreatic ducts, and the question was, should we bridge? And if yes, then how should we bridge? And I can tell you that I've upset many surgeons and some gastroenterologists. They've been angry at me for pushing the endoscopic options in this field because I feel that disconnected ducts beyond fluid collections belongs to the surgical domain. But I'll show you a few examples and see if you believe and you agree with me. So conventional wisdom is transluminal stents placed across the cystic alone are sufficient for most DPDS patients, one. And if this fails, surgery is the option. And we'll go over some cases and I'll ask you what your treatment would be and see if you agree. So this is a simple first case, somebody who had wall of necrosis, treated with percutaneous drainage 2 years ago with complete resolution of symptoms. Now, 2 years later, presents with abdominal pain, radiating to the back, no signs of infection, nice CT showing this large collection. Second case, 36-year-old with history of insulinoma of the pancreas, removed with enucleation. So this is not a necrotizing pancreatitis case, but I added this just so that I can bring up the disconnected duct. After surgery, she developed large intra-abdominal fluid collection and spontaneous anterior wall fistula where the pancreatic fluid was draining out from. And this is like, post-surgical. A drain was placed to treat the fluid collection, and it continued having high output, high amylase level pancreatic fluid. This is the, you can see the insulinoma in the head of the pancreas. They did not do any preoperative ERCP, and this is a CT scan a few days after enucleation. You can see large fluid collection actually tracking out through the anterior abdominal wall, leaking to basically she had a colostomy bag that was draining all this. So how many of you would treat this patient with surgical options? Anybody? Perfect. Case 3 is, again, another patient with wall of necrosis, managed with endoscopic drainage and necrosectomy. Transluminal stents were placed at cystic for indefinite placement. And now she presents 2 months later with recurrent lower abdominal abscesses. The abscesses were there for every month. She would have an admission for 3 to 5 days, septic sometimes. And again, the conventional wisdom is if you leave transluminal stents, this should not happen. So this is the third case. I'll go to the treatment options for this one. This one is, I added this one, again, a large wall of necrosis, which was not in good contact with stomach, was treated with percutaneous drain. The collection's gone, the drain is still there because there's a high flow of pancreatic fluid through this. So again, would somebody do surgery on this patient or would you prefer endoscopic options? So what is disconnected pancreatic duct syndrome? It's basically a disruption of the pancreatic duct in which two parts of the pancreas get separated. The viable tail or the body of the pancreas is not in continuity with the GI tract, so the fluid cannot make it to the ampulla and get out of the into the duodenum. This is a nice MRCP. You can see the pancreatic duct in the head, disconnection, fluid collection, and the duct in the body and the tail. Causes, pancreatitis is the most common cause, acute severe pancreatitis or necrotizing pancreatitis. Chronic pancs, surgical events, trauma. Prevalence, I think it's underreported. I would say it's closer to 39 to 40% in acute pancreatitis patients. Location, usually at the watershed blood supply area around the neck and the body where there's a reduced blood supply. So this was the most common place for your disconnection. Clinical presentation, again, most patients, or many patients, I should say, remain asymptomatic. So far, disconnected pancreatic duct syndrome was diagnosed basically by presence of recurrent or new fluid collections. But recurrent acute pancreatitis and chronic abdominal pain are common symptoms and really underreported in the previous studies. And this is very important to recognize. Lower abdominal abscesses, persistent external fistula. Again, 1 in 4 patients with necrotizing pancreatitis have DPDS. That's a high prevalence rate. And this is from a short-term study from a recent study. So again, it is important to recognize that these patients will form DPDS, disconnected ducts. Again, when patients had disconnected ducts, they were likely to have more severe disease and a higher ICU admission, new onset and persistent organ failure, recurrent pancreatitis or chronic pancreatitis. It is also associated with endocrine and pancreatic insufficiency. And we know that DPDS leads to longer hospital stays and a higher cost to the healthcare system. Diagnosis of DPDS is usually delayed because of lack of understanding of the disease. If they don't present with persistent fluid collections or recurrent fluid collections, people tend to ignore the entity. How do you diagnose DPDS? We have CT scans, MRCP, ERCP, and you can also add EUS to this. I'll go briefly over it because we all see these patients on a regular basis. CT scan will show you absence of pancreatic parenchyma with fluid collections. There'll be non-enhancement of the section of the pancreas neck of the body. That's most common presentation. And then you'll also see a viable enhancing segment in the tail to show that there is actually viable pancreas. MRCP is actually very helpful. You can follow the duct and you can follow the disconnection or disruption. ERCP, in some cases, it is required, where you would see complete cutoff when you go for the retrograde cannulation. There's no filling of upstream duct. In some cases, EUS guided duct access can be done to confirm or establish the diagnosis, but it's rarely needed. Management, if you look at the old guidelines, number 1 is watchful expectancy, which almost never works. Then you have the endoscopic transluminal drainage of the peripancreatic fluid collections, either at the time of initial necrosis or subsequent fluid formations. We've added endoscopic transpapillary drainage, endoscopic transluminal drainage. These are more of a recent development, I would say. Surgical drainage or resection of the disconnected pancreatic remnant. And this is something that's more investigational, I should say. I have a couple of cases, but I'll show you one. So again, the traditional management of DPDS, because diagnosis depended on having a fluid collection. So the traditional management was always transluminal stents. In most published cases, this has been the focus of their topic of the management. Conservative management almost never works. People have tried octreotide to see if that will help reduce the pancreatic exocrine function. It doesn't really help with the closure of fistula. If you do have to put them on, some people have tried TPN, but enteral nutrition is preferred no matter what the treatment approach is taken. Transluminal drainage, that's been the big topic. So if you have a patient with pancreatic necrosis and if DPDS is suspected, you should leave plastic stents after you've drained, and they can be left indefinitely. Or if there is a recurrent fluid collection and it's adjacent to stomach or small bowel, you could do transluminal drainage at that time and leave the stents for long-term or indefinite. The steps of transluminal drainage, this is somebody with large wall of necrosis, a large recurrent fluid collection. So you access under EUS, dilate the tract, leave double pigtail stents. 1 year later, the stents are still there, the collection's gone. So the case 1 that we did, we saw a lady who had recurrent collection 2 years after. That was the easiest of all management because we could see the collection across the stomach wall, puncture it, and leave plastic stents. In this patient, to confirm that they actually had DPDS, we also injected the pancreatic duct, and you could see the leak across into the collection. So the question is, do the transluminal stents actually work? This is from 2021. In this study, they show that patients, 188 patients who had endoscopic drainage with lamps, they were followed prospectively. After the lamps were taken out, they placed double pigtail stents, which was successful in 75% cases. Recurrent pseudocyst was present in 25%, where these stents were not placed versus 1.4% where the stents were placed. So this was significant. In this study, they showed that presence of pigtail stents reduced the formation of recurrent fluctuations. The same group had earlier, so they recommended placing plastic stents once the metal stents are taken out. This is from the same group, but 10 years ago. Again, they show that recurrence of fluid collections was lower if you had permanent transluminal stents versus when the stents are removed. But the data are not very similar in other cases. So this is a study from Pancreatic 2013 from Dr. Bassin's group, PGI. And if you look in patients with spontaneous stent passage, 4 out of 5 remain asymptomatic. And where there was no stent migration, there was, there was all remained asymptomatic. Symptomatic recurrent was not there. This is from Minnesota data. Again, patients who had acute necrotizing pancreatitis, asymptomatic 44 patients, of which 27, there were no stents. And in the symptomatic ones, stents were still present, 11. So again, stents were not really protective. And this is a great study from here. I think Sandeep is here and other authors are here, where they showed that there was really no difference in patients who had stent versus no stent as a primary outcome. So the data are kind of are not very clear to see if transluminal stents protect from recurrent fluid collections, but that's still the norm of placing or leaving the stents in. So question is transluminal stents, is that all that we need? So this is the case, one of the cases that I presented in the beginning. So this is somebody who had necrosis. We left stents, and here you can see the plastic stents that are left in. But what you see is pancreatic duct that is ballooned up in the disconnected body and tail of the pancreas. We dilated all the way to the tail. And she is now presenting with recurrent abscesses in the lower abdomen, right here. So if you were to look at the guidelines, she has a plastic stents, so she should not have all these problems, right? But she does. So question is, when DPDS presents without fluid collections, what are your treatment options? And because that's when the biggest issues or the challenges come through. So here, this is somebody with disconnected duct, and you have a dilated duct in the body and tail, presenting with recurrent pancreatitis and chronic pain. So here, this is a schematic of walled-off necrosis, 2 parts of the pancreas. And I feel as the collection resolves, the duct actually scars right here at the point of disruption. And why? Because remember, walled-off necrosis is actually walled. So there is a wall. So this would lead to a formation of scar in this area. And with that scarring, you would see dilation of or obstruction of the main pancreatic duct upstream to it, and that would lead to other problems. Do lamps and large bore metal stents play a role in this? Because we're seeing more of this now. It is possible because there's pretty rapid collapse of pancreatic necrosis collections when you put lamps. Maybe that's also contributing to formation of more ductal obstruction and dilation in these patients. But we don't know for sure. What does the hypertension or high obstruction of pancreatic duct lead to? Asymptomatic to atrophy and diabetes, recurrent collections and abscesses with persistent external fistula in some patients. It can lead to recurrent pancreatitis or chronic pancreatitis and abdominal pain. So these are all the possible presentation of, of these patients with ductal obstruction. So in these scenarios, you actually now call the surgeon, but I think you should make the call to the gastroenterologist and endoscopist for help. Now, what are the treatment options now? Transluminal stents, if the collections are accessible, but if the collections are not accessible and the duct is dilated or it's leaking outside, you could go for duct reconnection, which could be either ERCP or US guided. You could do a US guided duct drainage into the lumen of stomach or small bowel, or complete occlusion of the duct in the disconnected gland, and I'll show you that case. US ERCP guide duct reconnection is basically it's simple retrograde ERCP where stents are placed across the papilla through the area of disconnection into the upstream pancreas. Again, not always successful, but if you can get a stent across, it requires long-term stent therapy. This is a case of somebody with severe acute pancreatitis with large gastric varices who present with recurrent intra-abdominal abscesses. CT and MRI showed necrosis of neck and viable upstream pancreas. And because he had large gastric varices in the body and antrum, I did not want to try EUS-guided approach. I went straight for ERCP on this patient. You could see wire in the head of the pancreas. And then this was the collection where it was disrupted. With a bidirectional bending cannula and an angled wire, I was able to somehow, luckily I would say, find the duct upstream of the disconnected gland. You could see the contrast going up, bridge the two parts of the pancreas together, and this is 3 months later. There's still a stricture here, but at least the duct is not as distended anymore. This patient's pancreatitis resolved, abscesses went away, and he's done well since. He required some stent exchanges. After 1 year, I took the stent out, and this part of the gland has most likely atrophied, but he's doing well with it. So that was ERCP approach. How about EUS guided? It's a complex procedure which requires both EUS and ERCP skills and requires basically passage of wire through the disconnected duct into the necrotic area and out through the papilla. But also gives us transpapillary drainage. Again, it also requires long-term stent therapy, and I'll show you a video of that. So this is the schematic. We basically access the duct in the disconnected gland, get the wire across to the, if you can get it through the papilla into the duodenum, and then basically follow that with a stent. And over time, this would cause, over time, this area would stricture down, and you can leave, and this part of the pancreas, the duct will decompress, maybe atrophy. And after maybe a year or so of stent therapy, you could actually either pull out the stent or keep exchanging, depending on the scenario. This is one of the cases we did at Minnesota with Dr. Arain, 53-year-old with necrotizing pancreatitis, treated with endoscopic drainage. Transluminal stents were left in place as per guidelines, and he presented with lower abdominal abscesses. So you can see recurrent lower abdominal abscesses here. Transluminal stents are still present. On the CT, you could see leak all the way down to the abscess. So this is the ERCP image. You could see disconnection of the duct here with leak of contrast out in the necrotic area and also the wall of necrosis. So we left a stent across. There's also, so then we access the pancreatic duct in the body and pancreas above the disruption. This is about 3.5 millimeter duct in the 3.7 in the body. And you would see a needle puncture, and we got the, here you could see the transluminal stents and the necrosis, wire into the duct, and we had to kind of push the wire. So here you could see the dilated duct, and there was actually leak from the duct towards the abscess in the lower abdomen. So with some effort, we are able to push the wire through the scarred down duct into the necrosis area, and with a balloon basically rupture that, and now got the wire into the collection, into the necrosis. Over this, we left a pancreatic or gastrostomy stent from the stomach, disconnected pancreas, ending into the collection. And after this, we went back to the ERCP, same session, because now we had a stent to target. We went back to the ERCP, cantilevered again. And now because we had a stent to target, we were able to get the wire besides, through the necrosis, besides the stent, into the disconnected duct. So now we have transpapillary stent bridging the two parts of this pancreas. And this was the first ERCP. We placed a 5-French stent. So you still have the pancreatic or gastrostomy stent and the 5-French stent. You can see the transluminal stents too. Follow-up ERCP a few weeks later, we took out the pancreatic or gastrostomy stent, replaced with a wider, larger size transpapillary stent. Here. And I'll show you the subsequent ERCP images. Here you could see reconnected duct. So that's the EUS guided duct reconnection. Again, it requires a lot of ERCP EUS skills. You're not always successful. Takes a lot of patience and work. So it's not an easy job. Moving on to the next option, that's the EUS guided duct drainage. And this is our patient. So what is EUS guided? It's basically you drain the disconnected gland into bowel or gastric lumen by placing a stent across the wall. So this is our case to the lady who had the enucleation. So here there was an insulinoma, which led to disconnected duct. And this was a CT scan post surgery. You see large amount of fluid, free fluid, tracking out of the spontaneous fistula and through the abdominal wall. She was miserable. The surgeon called me, said he had no surgical options, and see if I can somehow reduce the fluid around and get the inflammation under control. So this is the EUS guided access of the pancreatic duct from the body, and we got the wire in. I could not reconnect the duct. It was a tight stricture. They were completely separated because of the surgical scar. We placed a small 3 French pancreatic gastrostomy stent. This is a technique Dr. Freeman's group has developed at Minnesota. So we left the stent in. After place the stent in, you can see the stent into the pancreatic duct and entering the stomach. All the fluid has gone that you saw on the previous CT scan. The fistula healed. This is another view of the same pancreatic gastrostomy stent going from the stomach into the disconnected pancreas. But 6 weeks later, she presented with severe upper abdominal pain and low-grade fever. So we repeated the CT scan, and there was this fluid collection between the stomach and the pancreas, and that here, this is a nice video I would show. You can see the pancreatic gastrostomy stent in the stomach. Yeah. See the pancreatic gastrostomy stent through the stomach, exiting the stomach wall, and going into the pancreas. But you see how much space there is now between the pancreas and the. So that's a good point to remember that the pancreas body and tail is not stuck to the stomach. There is space. So whenever you do pancreatic gastrostomies, it is not a safe procedure because stomach will move in relation to the pancreas. And especially if you're using thermal cautery to burn through the pancreas, you're taking a higher risk of causing a leak at subsequent date. So now the question is, what do I do with this patient? Because they're not a surgical candidate. I can't replace the same pancreatic gastrostomy stent. So I thought, what's a safer pancreatic gastrostomy? If you look at stomach's anatomy, the part of stomach that's kind of fixed to the pancreas, so it does not move in relation to the pancreas, is the antrum and prepyloric antrum. Body, fundus, they all move, but the prepyloric antrum is almost stuck. It doesn't move in relation to the pancreas. So I switched my technique, and instead of puncturing from the body into the pancreas, I went back to the pylorus came to the intrum and stuck the pancreas through the prepyloric antrum and got a stent in retrograde manner into the pancreas. So what this does is this stent is stable. When the stomach moves, the stent will not move. And when the stomach moves, there will not be a leak. So we left this for a few weeks. This is a picture of that. You can see duodenum, stomach. You can see the stent entering the stomach into the disconnected pancreas. And we left this for a few months. This is the CT before we started the endoscopic therapy. This is post endoscopic therapy, and she's done. No further leaks. This is the paper from Dr. Freeman's group. 8 patients who required this procedure. Only 4 had DPDS. Technical success 88% in placing pancreatic gastrostomy stents. Clinical success 71%. There was one asymptomatic duct leak, and I think that was in the patient who had necrotizing pancreatitis. Patients with chronic panc and all did better, right? What is the long-term efficacy of this? This is an old study from 2011. Most of these patients are post-Whipple and asthmatic strictures or chronic panc. Stent dysfunction was seen in 50% patients. Long-term pain resolution in 72%. But again, these are chronic panc and duct obstruction from an asthmatic stricture patients. But it does work. It helps reduce the pain or other symptoms. Coming next to the ERCP guided drainage of the collection, this is an older technique where a transpapillary stent is placed into the collection, and over time it leads to a fistula that drains through the papilla. This is the schematic. So here you have wall of necrosis, and what you do is you basically leave a stent transpapillary ending into the collection, and as the collection resolves, it forms kind of a fistula between the two parts of the pancreas, and that keeps draining the disconnected pancreas. Again, low efficacy and success rates with the technique, so it's not really a favorite technique anymore. Coming to the third case that we had, 56-year-old woman with wall of necrosis managed with endoscopic transluminal drainage necrosectomy. Transluminal stents were placed and left indefinitely. Now she presents with abdominal pain and abdominal abscesses. So what are the options now? I tried duct reconnection, and that failed. Here you can see this is the initial necrosis that was drained and treated with endoscopic transluminal drainage. At the time, we used to use the Taiwan stents before Axios. The collection resolved, and I left the transluminal stents. She started developing abdominal abscesses, and she would present with fevers and sepsis. But you could see transluminal stents are there, and the duct above that was dilated. So we tried ERCP to see if we can fix with retrograde access, and here you could see duct in the head, complete disruption. I tried duct reconnection, but in this patient, the wire would not come out through the papilla. So because I had nothing else left, I went for EUS-guided glue injection to ablate the pancreatic duct in the disconnected gland. So this is EUS-guided access of the disconnected duct in the body and tail. We injected contrast, and you can see the contrast leaking through the necrosis, through the fistula, and this is the external drain that was placed into the abscess. You can, the contrast leaks all the way down to here. So you're able to pass a wire through this duct, through the fistula, all the way down to the abscess. You can see the wire coming down. So wire came down into the abscess where the drainage catheter was, and using a snare, we are able to grab this wire here. So now I have a wire that's going through the stomach, through the pancreas, area of disruption, and out through the skin. Over the wire, we got a second safety wire into the, we get a cannula and a second wire to the tail of the pancreas. That's a cannula being advanced over the wire into the tail. And now we wanted to see how much disconnected pancreas of the pancreas in the body and tail is left so that we could measure the volume of glue that would be required. So we actually then pushed the wire even further because there was some more pancreatic tail that we hadn't seen earlier. So now we are all the way to the end. So now we could figure out how much pancreas is left. So this is n-butyl cyanoacrylate or hystoacryl. We measured how much time it takes to solidify. It takes about 7-8 seconds. And through the percutaneous approach, then we injected to the tail of the pancreas, and you could see complete ablation, like, the glue was forcefully injected into the tail of the pancreas, into the fistula tract, and then out. The glue had some lipoidol, so you can see the contrast all the way to the body and tail. So this was done because she was having recurrent abscesses from the leak of pancreas. That night she was kept in hospital, had some abdominal pain. Next to the pain resolved. And I'll show you the CT scan from a year later. This is the CT scan 1 year after this. The pancreatic tail has atrophied. This was 2015, it's almost 9 years. Not a single admission for recurrent abscess or pancreatitis or pancreatic related complications, doing perfectly well. He has mild diabetes, which may be familial, type 2, not on insulin, just takes oral hypoglycemics. So the ablation of pancreatic gland, basically you're doing medical pancreatectomy without actually taking the pancreas out. It possibly preserves islet function. You're basically taking away the exocrine function. Now, question is, what is the ideal treatment for DPDS? So the treatment depends on the clinical presentation. When there is a non-resolving fluid collection, and if it's adjacent to stomach or duodenum or small bowel, basically transluminal drainage and long-term stents. When it is not adjacent to stomach or duodenum, you could try, if the collection cannot be accessed, then you could try US-guided internal drainage of the disconnected pancreas, either pancreatic gastrostomy or pancreatic duodenostomy. The transpapillary drainage if accessible. Surgical resection, but if you do, then consider IAT, islet transplant, because you would preserve some of the endocrine function there. And Roux-en-Y internal drainage is another option. For patients presenting with recurrent pancreatitis, which is about 40% of presentations of disconnected glands, US-guided internal drainage disconnected pancreas, just like we showed. Again, surgical resection with IAT and Roux-en-Y internal drainage, if these fail. Percutaneous fistula, I would manage similar as the previous option, internal drainage or duct reconnection. Again, surgery is the fallback option for you. So the question that Nalini posed was, should we bridge disconnected pancreatic duct? My answer is yes, because endoscopic therapy provides treatment options in patients who are not surgical candidates. Within the first year of severe acute pancreatitis, surgical treatment is not a good option. They have many times poor nutritional status, ascites, varices, ongoing peripancreatic inflammation. So no surgeon likes to go back in within the first year. The endoscopic therapy at the least gives you time for them to recover and get ready for surgery, if nothing else. Thank you. Thank you.
You're very aggressive in the management. And we find in our experience that disconnected duct is very common after acute necrotizing pancreatitis, almost to the tune of 75%. Not all of them require intervention. Those who have, as you rightly said in your table, that those who have recurrent pancreatitis or a fluid collection or pain coming because of disconnected, I think, then ductal hypertension. If a pseudocyst form, that's a straightforward case. Put a plastic stent, forget about it. But
Exactly.
those who have a duct which is dilated, we also tend to do more of EUS-guided interventions, putting a plastic stent, single pigtail or a straight stent more likely. What you nicely showed was you could reconnect the ducts. Maybe these cases are earlier in the course of pancreatitis when scarring has not formed. If it's a dense scar, then it's very difficult to go across it.
Like the first case I showed, there actually was a dense scar between the disconnected duct and the area of necrosis. So we actually had to use a balloon to push through. Because our aim at the time was to have a stent go all the way to the necrotic area. We were lucky that we were able to follow the stent and reconnect the duct, and we've done that since a few more cases. Doesn't work all the time. You have to have the wire just follow the stent up, but that's one option. I think recurrent fluid collections help and identify disconnected duct. At the same time, people tend to forget that other presentations, recurrent pancreatitis, chronic abdominal pain, abscesses, pleural effusions, that also are a part of disconnected pancreatic duct syndrome, and they get ignored, I think. And some of these patients live for a long time with abdominal pain, which could have been treated by a simple pancreatic gastrostomy or reconnection of duct.
Actually, Gautam from our group is accumulated all the work now. So over the last 10 years, we've done about 104 cases of EUSPD in various forms, in chronic pancreatitis and disconnected duct and external pancreatic fistula. I think we'll write up a paper and take your opinion on that as well. Thank you.
Rajiv, fantastic talk. One of the problem with this ductal disconnection syndrome is, of course, what you said is recurrent pain, fluid collection. But a chronic problem is that if it's undrained, it leads to pancreatic atrophy and new onset diabetes.
Yep.
So what we have found and published in gut also, we see what is the level of obstruction. If the level of obstruction is genuine beyond and whole pancreas, which is left beyond, is not drained, and even if it is not symptomatic, may lead to atrophy and diabetes. So if the disruption is towards tail and very less amount of pancreatic parenchyma is atrophied, it's not a much of problem. But if the long duct and long big pancreatic tissue is left behind, it is more problem. So we must do the drainage, even if they are not symptomatic. Maybe a surgical drainage may be option, because if there is a 5 French or 7 French stent, may not be good for a long-term drainage.
No, I agree, because that's what I said. Like, surgery is a good option. I'm not saying surgery is not the option, but you need to buy time. The first year after acute pancreatitis is when you would want to avoid surgery. But if you can buy time by using endoscopic means, see them through, then yes, surgery is a definitive treatment. And surgical drainage rather than surgical resection.
Hi, Raju, excellent talk. So my concern is regarding these abscesses. So the basic principle in treating the abscess has to be, the pus has to be drained. But if you put a stent, even the 5 French or 7 French stents, how does this abscess, which is there already, it heals up? Because even if you establish the drainage, the abscess cavity, does this abscess resolve because of this drainage? Or
So basically going for source control, right? So the source is a duct leak getting into the or causing the abscess. So you're draining the abscess by percutaneous means, like a normal abscess you would, but then you also have to control the source of the leak. And the source of the leak is the disconnected, dilated, obstructed pancreatic duct that's leaking down.
that part is fine. If the leak is, deformation will not happen. But abscess cavity, until unless we drain is completely, the stents will get clogged in no time.
No, I'm putting the stent only in the pancreatic duct. This we're draining or managing with the IR means anyways, just normal. Percutaneous, yeah.
You have to combine it.
Yeah. They always get a percutaneous drain when they come in with fever, sepsis. Yeah. So yeah.
Just curious to know how many of these glue injections you've done so far, and
I've
how's
done
the overall
2.
experience?
So after the first glue injection, I got so much pushback. Like, I actually got disinvited by a course. So it's very selective. I only when we fail with everything else that we think of it. And again, it's not published. It's not a norm. So only if the patient agrees to it.
Okay.
So So basically, on the wire, I get a small balloon, a 5 French balloon just from IR. Take it all the way to the tail of the pancreas, push. But you remember, you have only 8 seconds to fill up the pancreas and get the glue out. So it has to be fast, rapid push while you're pulling the balloon back.
Nip Sohendra described it many years back, about
For
20 years
chronic
back.
pancreatitis.
Chronic pancreatitis, Nip Sohendra is doing.
Yeah.
And then in one patient, there was very severe pancreatitis, so he stopped actually after that.
Yeah, so that is the risk, because when you're occluding the duct, you will get pancreatitis. But again, in these patients, a small part of the gland, that's the culprit. So I've told the patient beforehand that they'll have pain the first night. So we give them analgesics.
What's
and
interesting is the concept that maybe diabetes doesn't come in these patients. But
yeah.
this is an interesting concept here. Just
Yeah, because you're doing a medical pancreatectomy, essentially. You're taking the exocrine function away, preserving the endocrine glands. And So if you were to do a resection, unless you do islet transplant,
This is very interesting, but then actually we can try out in the animal lab, ligate the pancreatic duct, then inject glue and see what happens, whether these lose not only the SNR function, the islet is preserved.
Preserved,
That would be interesting
Yeah.
concept.
yeah, over time, it's a long term, but again, you buy time, right? You're giving them longer time than as compared to, say, resection.
I think we should thank you, Rajiv, for that excellent talk.
All right. I think in the last few minutes, we tried to cover everything from, complications happen to all of us. If anybody in the room says they have not had a complication, that means they've not done enough procedures. But we need to recognize, acknowledge that these things happen. And Dr. Freeman has done his life's work on trying to not only just recognize, keep track of it, study, and then try to do something to improve. And Michelle has, as luminal endoscopist, we always think within something. So she has told us in chronic pancreatitis, we need to look beyond the duct, look at the entire pancreas as a gland. And Rajiv has shown how you can successfully manipulate and bridge the gap in pancreatic duct disruptions, and why it's important to understand the pathophysiology of the entire pancreatitis and the process to do this. So thank you all for coming and accepting this invitation and giving a talk.
Thank you, Dan. Thank you for organizing all this, Nalini, because coordinating and getting such excellent speakers here to AIG. Thank you very much for coming. And it's a tradition in India that when you come, that we actually have this shawl marti. So this is cool actually in Minnesota. When it's cold, it's